دكتور حمزة سامعني؟ الصوت واضح؟ ممتاز. خليني أعمل سكرين شيرينج. اوكي، شايفينهم السلايدز؟
دكتور واضحة.
طيب إذا صار في أي interruption أو connection issues throughout the lecture دكتور let me know. اوكي، يعني تخلونيش أحكي وأنتم مش سامعين إشي. is it an ولا 40 يعني أنا مرتبط ولا أنا time at the end of this lecture, which is just 40 minutes. أحيانا كانوا يحكوا لي uninterrupted session يعني ما يكون في limited time بس we'll try our best. We'll see. So I will go ahead and start. Today's topic is about headache disorders and facial pain. This is a big topic, and actually headache is the most common complaints patients have in the neuro outpatient clinic. It's a symptom that is commonly encountered in everyday practice. So it's important that everyone know or have an idea about the different types of headache, the differential diagnosis, and how to diagnose them, how to make sure you exclude serious causes or what we call red flags for secondary causes of headache. Here we have the outline of this talk. So first we will start with the most recent classification of headache disorders and facial pain from the International Headache Society. We'll go over the red flags for secondary causes of headache. We will also describe the clinical features of common headache disorders, and we will review only the basic treatment guidelines, not so much details for different types of headache disorders. So this is actually the most recent classification of headache from the International Headache Society. So simply they divide headaches into primary headache disorders, secondary headache disorders, and neuropathies with facial pain. So primary headaches means there is no underlying cause for the headache, and this includes the migraine, tension headache, and the cluster headache. Secondary causes of headache are multiple. I will list some here in this slide. So headache attributed to trauma or injuries to the head or the neck, headache attributed to cranial or cervical vascular disease. So any vascular disease like the stroke, subarachnoid hemorrhage, epidural hematoma, or subdural hematoma, any of that can cause headache. We call it vascular cause. Headache attributed to non-vascular intracranial disorder like the high or the low CSF pressure disorders. Headache attributed to infections like encephalitis or meningitis. And finally, we have the neuropathies or facial pains like trigeminal neuralgia, occipital neuralgia, and glossopharyngeal neuralgia. And today we will spend some time talking about all types of primary headaches, including the migraine, tension headache, and cluster headache. We'll talk about two examples of the secondary headache disorders, including the giant cell arteritis, that's an example of the vascular diseases, and headache attributed to non-vascular intracranial disorders, mainly the high CSF pressure disorder. The last topic will be the trigeminal neuralgia, an example of the neuropathies. So, 1 minute. I have to go back. So the differentiation between the primary and secondary causes of headache is very critical. It dictates the diagnostic approach and guides the treatment and the prognosis. So it's very important to take a detailed, thorough history. In most of the cases, you will find the answer in the history. So we ask about the location where the pain is, the duration, how long does it last, the nature of the pain, whether it's throbbing or pressing or tightening in nature, We ask about the severity of the headache, whether mild, moderate, or severe. If there is any associated symptoms like nausea, vomiting, phono or photosensitivity, any exacerbating or relieving factors, what makes it worse or better. Family history is also important. Most of the migraine patients, for example, they will have a family member with migraine. In the physical exam part, we look for signs of focal neuronal dysfunction or focal neurological dysfunction, like a weak arm or a weak leg. This can suggest a secondary cause or intracranial pathology. So focal neurological dysfunction by exam is something that we look for in the neurological examination, neuro assessment. And here we have the red flags for secondary causes of headache. So you take detailed history and you keep in your mind that this could be, this headache could be to underlying intracranial pathology. So we screen for red flags with a SNOOP, S for systemic signs and symptoms, including the fever, meningismus, vomiting, immunocompromised state, all of that suggests CNS infection. Anticoagulation or blood thinners in general, this can suggest intracranial bleed or bleeding. The N is for neuro symptoms like altered mental status, weakness, seizure, all of that suggests, again, intracranial pathology. Onset, O is for the onset, if it's abrupt or severe. And we have an example for the worst headache in life ever. That's suggestive of a subarachnoid hemorrhage. If the headache is associated with sneezing or straining, this is suggestive of posterior fossa pathology. The other O is for older age at onset, so more than 45 or 50, then this should raise the concern for secondary causes of headache. P is the progression of the headache. If there is worsening of the severity or frequency over time, then again, you should think about secondary causes of headache. So you sit with the patient, you take detailed, thorough history, and you also screen for those red flags summarized in SNOOP. So the next is, we will talk about the primary headache disorders. The first one is the migraine headache. This is divided into migraine with aura. It's called the classic migraine, migraine without aura, or the common migraine. And also we have the chronic migraine. We'll tell you the definition in a few minutes. I'll skip this slide for the sake of time. I don't think you need to know the details. So common migraine is migraine without aura. It is characterized by recurrent headache disorders manifesting in attacks. And each attack will last between 4 to 72 hours. So a few hours to few days. Unilateral in location, so in one side, that's the most common form. Around 70% of the patients with migraine, they will have unilateral pain, but can be bilateral, especially in young population. It's pulsatile in nature or throbbing in nature. It's moderate or severe in intensity. So migraine pain is not mild. Usually aggravated by routine physical activity and associated with nausea, vomiting, phono, or photophobia. So the loud noise or the lights can make it worse. The classic migraine, it's a migraine pain, but preceded by symptoms. It's called auras. So aura is defined as complex of neurological symptoms that occurs usually before the headache, but it may continue into the headache phase. The key is that these symptoms, again, are fully reversible. So patients are okay in between attacks. And again, they're always or most likely to be unilateral, so in one side. And each aura, they last between 5 to 60 minutes in duration. They manifest in different ways, but the most common form of auras associated with the migraine is the visual aura, occurring in over 90% of the patient. So patient can describe visual field defect, flashing lights, the zigzag lines, scotomas, like you can see in this picture, some flashes of light or blurring of the vision or zigzag lines preceding the migraine pain. So that's called aura. Remember, it's in one side, so unilateral, and it's fully reversible. They last between 50 to 60 minutes in duration, but they go back to normal in between migraine attacks. Next in frequency, auras can be sensory. They can describe sensory disturbances in the form of pins and needles. They can be motor too. They can have some, we call it hemiplegic migraine, some motor symptoms. But the most common auras associated with the migraine are the visual auras. Again, to remind you of the 4 phases of the migraine, we have the prodromal phase, where patients report being sick, fatigue, difficulty concentration, nausea, vomiting, blurry vision, up to a few days in duration. And this is followed by the aura, again, lasting between 5 to 6 minutes in duration, followed by the migraine pain, a few hours to few days, maximum 3 days. And this is usually followed again by the postdromal phase, which can last up to a day or 2 in duration, where patients report fatigue, the changes in the mood, again for a few days. How do we define chronic migraine? So it's headache occurring on 15 or more days per month for more than 3 months in duration. So we ask the patient, how many pain days do you have in a month? If it's more than 15 for more than 3 months, this is consistent with chronic migraine. So it's not only the severity that is very important to be determined, but also the frequency of the headache, and this is important in terms of treatment. So for the treatment of migraine, we have acute abortive medication that is used at the time of the pain to ease the pain. It's called acute medication. Can be migraine non-specific painkiller medication, over-the-counter pain medication like non-steroidal, for example, anti-inflammatory drugs, or migraine-specific medications called triptan, designed specifically to abort the migraine attacks, like sumatriptan, for example. They are very potent restrictors, so they have some contraindication like ischemic heart hypertension, but again, very effective, used to abort the migraine attack. For the preventive prophylactic medication, we use some drugs to decrease the frequency, the duration, and the severity of the migraine in the future if they are enough, like chronic migraine pain, for example. You can give acute abortive drugs, and you also can prescribe preventive prophylactic ones. We have so many options, including the tricyclic antidepressant like amitriptyline, the beta blockers like propranolol or Inderal, the anti-seizure medication like topiramate or valproate, botulinum toxin injections, also FDA approved now for the prevention of migraine. And we have something called calcitonin gene-related peptide released recently. The first one was in 2017 and approved prevention of migraine attacks. That's briefly, again, just the basic treatment guidelines for the migraine. The tension type headache, so it's defined as infrequent, frequent, or chronic headache, usually bilateral on both sides. It's pressing in nature, lasting minutes to days, and the pain does not worsen with routine physical activity. And it's not usually associated with nausea, although photophobia may be present. So to compare this to headache, tension is bilateral, migraine is more likely to be. This is pressing or tightening, but the migraine is dropping or pulse. Tension mild to moderate, but migraine is moderate to severe in intensity. It can last hours, a few days. Tension headache is not usually exacerbated by physical, but migraine is. And the associated symptoms like nausea or photophobia are more likely to be seen with the mic than the tension type headache. Again, for the treatment, acute with a simple over-the-counter pain medication, you can use, if it's a frequent headache, you can use one of these preventive medications like topiramate, the amitriptyline, or some muscle relaxant can also help with the prevention or as a prophylactic medication for tension type headache. Next is and it's defined as very severe attacks of pain, very severe excruciating pain, used to be idle pain. It's a strictly unilateral, so almost always one side and doesn't switch sides. So migraine is usually unilateral by each side, sometimes on the right, sometimes on the left, but this cluster headache is almost always in one side. The most common orbital or supraorbital. The duration is shorter than the migraine and the tension. They can last between 50 to 180 minutes in duration. And the frequency is variable, so once every day to multiple 8 times per day, so really variable frequency. The pain is associated with symptoms, but symptoms, mainly autonomic manifestation like conjunctival injection, redness, for example, lacrimation, nasal congestion, rhinorrhea. It can also describe facial sweating, meiosis, orthosis, or eyelid edema. If you see any of that, it's highly suggestive of cluster headache. That's different associated symptoms with migraine and tension, which is mainly phono and photosensitivity. So if you have a patient with very, very attacks of pain, mainly in one side, the eye, involving the orbit, lasting for a few hours to few minutes to few hours in duration with ipsilateral autonomic manifestation, then think about a cluster headache. So in this picture on the top, you can see the cluster of very frequent attacks, so short-lasting headache in one side, and this is a period of remission. There is no headache in between. This can last between months, and then another cluster of short-lasting frequent headache. That's cluster because it occurs in clusters. Provoked by alcohol and night, so very for unknown reason, men are affected. We have options for the acute treatment. First, the oxygen therapy, 100% for 15 minutes at a flow of 12 liters per minute, to be diagnostic and therapeutic at the same time. If you have a patient and you think this is he has a cluster headache, to the emergency room to take oxygen therapy, and they improve, and that's diagnostic therapeutic. So there is significant improvement with oxygen therapy for cluster. Other options, you can use oral medications like triptan and the ergotamine, both very potent vasoconstrictors found to be effective to support the cluster headache. And for the preventive, to prevent again further attacks in the future, we have calcium channel blocker, Hamil, the lithium, or the seizure medication like topiramate or the valproate. So to summarize everything in this nice table, migraine versus tension versus cluster headache. Migraine, most of the patient unilateral, but can be bilateral. Tension is bilateral, and cluster almost always in one side, and it doesn't switch sides. Migraine, moderate to severe intensity. Tension is mild to moderate, and cluster is very severe in intensity. Migraine and tension, they both last for a few hours to a few days, but cluster headache, a few minutes to a few hours. Nausea, vomiting, photosensitivity, more likely in migraine, less likely in tension. Different associated symptoms, mainly autonomic manifestation with the cluster headache. Please, this table. So next, the giant cell arteritis. It's an example of the secondary causes of headache, mainly vascular. So it's a systemic inflammatory vascular form of vasculitis of unknown etiology, more common in patients, and can result in a wide variety of systemic and neurologic and complications. So it's not only the neuro manifestation, they can also have ophthalmologic and systemic manifestation. It can affect large medial arteries, particularly the superficial temporal artery, and that's why we call it temporal arteries. Again, the age, more likely in elderly, more than 60, and the incidence will increase with age. Female to male ratio is 2 to 1, so more common in females. Okay. So how do they manifest? What are the clinical features with giant cell arteritis? Again, headache, and the headache has non-specific features. There is a strong association with the PMR, myalgia rheumatica, multiple joint pain and stiffness. They also report fatigue, jaw claudication, which is pain in the jaw with chewing or eating or talking, and also fever. So neuro and systemic motion. Around 50% of the patient, they will have visual symptoms, and it can be transient, intermittent, but if left untreated, can result in irreversible vision loss. And this vision loss is secondary to the vasculitis affecting the posterior ciliary artery, causing anterior ischemic optic neuropathy. So again, vision loss can be permanent or irreversible if this condition is. Physical examination, we have clues on the physical superficial temporal artery tenderness. If you press on the medial side of the head, you can induce the pain. It's called tenderness. So temporal artery tenderness is suggestive of giant cell arteritis. We also look for signs of optic neuropathy, like decreased visual acuity, color vision, or field defect by confrontation test. So if you have a patient with a combination of headache, some of the more systemic manifestation, and you do by physical examination, you find by physical examination you find superficial temporal tenderness and signs of nerve dysfunction, then you have to think about arteritis. Blood test includes the ESR C-reactive protein, usually high, but can be normally around 7 to 20% of the patients. So normally ESR C-reactive does not out this condition. The gold standard for diagnosis is really the biopsy. You need a superficial temporal artery biopsy to confirm the diagnosis. In this picture here, you can see narrowing of the lumen of the affected artery and by the tonica media, and accumulation of the lymphocyte and inflammatory cells, include cells around the internal elastic membrane. So that's the things in giant cell arteritis, and this is a comparison between the normal artery and the artery affected by vasculitis. Again, tonica interna, tonica media thickening, narrow, and you can see the giant cells and the inflammatory cells accumulating around the internal elastic membrane. So biopsy is the gold standard for because the visual symptoms can occur rapidly and irreversibly. The treatment must not be delayed while the biopsy is being arranged. A high index of suspicion for giant cell arteritis, you have to start the steroid to prevent vision loss, permanent vision loss. Universally accepted the treatment for giant cell arteritis is high-dose steroid therapy. The steroid does not really affect the result of the biopsy. Those histological changes maybe still be seen for a few weeks initiation of a treatment. So remember, elderly patient, combination of neuro symptoms, systemic manifestation, ophthalmological manifestation, temporal tenderness by examination, and signs of optic nerve dysfunction, plus high ESR C-reactive protein and arrange for the biopsy. The result of the biopsy will take to be revealed, so you don't have really that time. Okay, next is the trigeminal neuralgia, defined as abscess of unilateral facial pain and the distribution of the trigeminal nerve. And the pain has all of the following characteristics. So it's very short lasting, a few seconds to maximum 2 minutes. Very severe and described by patients as shock-like shooting or stabbing pain, and usually precipitated sensory stimuli within the affected trigeminal distribution. It's not common for patients to describe this pain when they brush teeth or put makeup. So precipitated by sensory stimuli. It can actually induce panic if you tap over what's so-called trigger zone behind the ear. You can induce the trigeminal neuralgia. So sensory stimuli, pain-induced or precipitated by sensory stimuli. Usually idiopathic, we don't have an underlying cause, but we like to screen for space occupying lesion in contact with the affected trigeminal nerve, like in the right, the top of this slide, compressing the trigeminal nerve. and rule out a neurovascular compression and artery compressing the trigeminal nerve. MS plaque, a disease called multiple sclerosis, cause demyelinating plaques at the trigeminal root zone or in the pons, for example, in the brainstem, affecting the intrapontine afferents. So this can cause, again, trigeminal neuralgia. MS is more in young patients, predominantly the female patients between 30 to 50. So we do that, MRI to rule out MS plaques in the appropriate clinical context, of course. So remember, tumors, trigeminal nerve, neurovascular compression, that's another cause, and multiple sclerosis in certain patients. How do we treat the with some options? Medications include carbamazepine, mainly seizure medication, carbamazepine, gabapentin, topiramate, lamotrigine. If patients fail the medical treatment, we can use one of these options, surgical options, microvascular decompression, like repositioning of the artery, compressing the trigeminal nerve, radio frequency thermal legioning, so damage trigeminal nerve to prevent or treat trigeminal neuralgia. Brain stereotactic radiosurgery with gamma knife. Gamma knife is a device deliver specific beam of radiation to the trigeminal nerve, damaging it. Helps to ease the pain of trigeminal neuralgia, but we only use options if patients fail the medical treatment. How much time do we have, Doctor? Okay. سامعني؟
دكتورة في 10 دقائق إن شاء الله.
ممتاز. Okay. So the last thing we will talk about is the pseudotumor cerebrum. This entity had a lot of names in its history. So used to be called in the past benign intracranial hypertension. The name because they found it's not really benign. So this is order of etiology, predominantly affecting the obese women of childbearing age, females. The main problem is chronic elevated intracranial pressure. And the most important in neuromotion is papilledema because of the optic disc swelling secondary to increase in pressure. And this can lead to progressive optic atrophy and vision loss in blindness. And that's why they changed the name to idiopathic instead of benign intracranial hypertension, because it can cause vision loss. It's not really benign. Again, the etiology is unknown, but we screen for secondary some medication, antibiotics, vitamin A, venous flow, some endocrine disorders, obstructive sleep, and head trauma. All of that can cause increase in the intracranial pressure. If there is no secondary cause, if you can't find any underlying cause with the extensive workup, then it's called idiopathic intracranial pressure. How do they present to you? Signs and symptoms of increased intracranial pressure. They have headache. Most of the patients, 50% of the patients, they will have headache. Again, no distinguishing characteristic. Describe worsening of the headache when they lie down. Have some transient, intermittent blurry vision or blackout vision in one or both eyes, lasting for a few seconds to a few minutes. Again, if there is left untreated, it can cause blindness. Double vision or binocular diplopia, meaning they see double only when things with both eyes simultaneously. If you cover one eye, the double vision will go away. It's called binocular diplopia. Pulsatile tinnitus is also in this entity, pseudotumor cerebri, idiopathic intracranial. The next thing that you want to do into their eyes, vision evaluation or optic nerve function assessment is part of neuro examination, and we routinely do for all patients with headache to rule out papilledema, optic disc swelling secondary to increase intracranial pressure. And in this in pseudotumor cerebri or idiopathic intracranial hypertension, you will see or you will find bubble edema by fundoscopy. So fundoscopy is very important in the evaluation of all patients with. We also assess for visual acuity in both eyes, the assessment either in the clinic with a confrontation test or with a modified test in the ophthalmology clinic using a test called PERIM. Can tell you if there is any visual field defect. Ocular motility exam also is important. You can see 6 nerve pulsing abduction, secondary again to involvement of 6 nerve due to intracranial pressure. So if you have a young obese patients, chronic headache, some visual symptoms and tinnitus, of course you do fundoscopy. For all headache patients, fundoscopy, you see bubble edema, then the step you want to do is to rule out a space occupying, because those patients has signs and symptoms of increased cranial pressure. So the next step is rule out space occlusion, a tumor, for example. So we do that with the brain MRI, and we add MRV to rule out venous sinus thrombosis, which can cause increase in the intracranial pressure. There are several other radiological signs of cranial pressure. You don't really need to know all of them in details. In have empty sella torsica. In B, we have a flattening of the back of the globe, the eye globe. And in C, you have tortuosity of the optic nerve and the narrowing of the transverse here in D. Okay, so signs and symptoms of increased intracranial pressure, but in pseudotumor cerebri, you do brain image by space occupying lesion, and the brain image is usually normal. There is no tumor. So signs and symptoms of increased intracranial pressure, no tumor. Hence the name pseudotumor cerebri. So there is no space occupying lesion to explain the increase in. If you rule out a space occupying lesion, you can go ahead and do longer to confirm the increased intracranial pressure. Normal opening pressure, so we measure the opening pressure with this device and this picture. So the opening pressure between 100 to 200 millimeter. If it's more than 250, diagnostic for this disease. So high opening pressure by lumbar puncture confirm your diagnosis. It requires the diagnosis of edema, again, signs and symptoms of increased intracranial pressure, normal level of consciousness, normal MRI, there is no tumor, there is no space occupying lesion. The signs that I already showed you or mentioned. And we do lumbar puncture to measure the opening pressure, which is usually high. And the normal composition is normal, meaning there is no white BC, there is no infection, there is no meningitis or encephalitis to explain increased intracranial pressure. So sign pressure, normal brain image, there is no specific occupying lesion, high pressure by lumbar puncture with a normal CSF composition. That's diagnosed pseudotumor cerebri or idiopathic intracranial hypertension. How do we treat these patients? Treatment goal for all patients with idiopathic intracranial hypertension is to preserve the optic nerve function and monitor the increase in intracranial pressure. So optic nerve function should be monitored in each visit. We recommend weight control for all obese patients. We give them medications like the carbamase inhibitor, the acetazolamide, to lower the intracranial pressure, as include topiramate, which is a C-germ, has a similar mechanism of action like the acetazolamide, the carbonic anhydrase inhibitor, intracranial pressure. Diuretics is the least commonly used for this entity. If patients fail the medication, we have surgical options, nerve sheath fenestration, to release the pressure of the nerve to preserve the vision. So that's called decompression, optic nerve fenestration, optic nerve sheath fenestration. It usually helps with the vision or visual symptoms, but it doesn't really do much headache. Other options include cerebrospinal fluid diversion. So we do shunting, lumboperitoneal shunt or ventriculoperitoneal shunt. So you divert the CSF to release or decrease the intracranial pressure. Again, you use the surgical option whenever patients fail the medical treatment. You use medications, acetazolamide or topiramate or the combination. And if they fail, they continue to progress. There is no significant clinical improvement. There is worsening papilledema by fundoscopy. Then you should send them to surgery for diversion or shunt. To summarize, headache is very common. It's maybe primary or secondary. Secondary meaning potentially life-threatening causes. And the differentiation is very, history is the key whenever you evaluate patients with headache because it dictates the diagnostic approach, the treatment, and diagnosis. Remember, you have to know all the primary headache disorders, the trachea, giant cell arteritis, and examples of the